Greetings, enthusiasts of the medical world, and a very warm welcome back to ERMP and Beyond, your premier destination for delving into the heartbeat of clinical medicine. As always, we're set to navigate the practical aspects of medical science, dissecting intricate cases that both challenge our intellect and expand our knowledge. In this platform, we confront the real-world scenarios of healthcare. Together, we'll deconstruct complex diagnoses and sharpen our clinical acumen. Anticipate engaging and dynamic, evidence-based dialogues, enriched by the priceless perspectives that stem from actual medical practice. So, without any delay, let's dive into the depths of today's medical enigma. A 76-year-old male diabetic and hypertensive patient presented to the emergency department with chest pain and diaphoresis of 30 minutes. ECG shows ST segment elevation on lead 2, lead 3 and AVF with reciprocal changes. The troponin result is pending. What is the next best step in the management of this patient? A. Wait for troponin result. B. Consult cardiologist for possible percutaneous coronary intervention. C. Do echocardiography and consider dual antiplatelet. D. Start therapeutic dose of anticoagulation after troponin. Dear ERMP and Beyond followers, let's delve into the essential steps in the management of acute ST segment elevation myocardial infarction case. Our focus is on the urgency of action to mitigate the risk of mortality and lasting damage to the heart muscle. Firstly, we need to assess and stabilize the patient's airway, breathing, and circulation. After that, rapid diagnosis is paramount. We must swiftly identify STEMI by evaluating clinical symptoms, scrutinizing ECG for ST segment elevation, and noting elevated cardiac biomarkers. It's imperative not to delay for troponin results, as time is of the essence. Once diagnosed, continuous ECG monitoring is crucial. This allows us to promptly detect any life-threatening arrhythmias that may arise, enabling immediate intervention. Establishing intravenous access is another critical step, ensuring we have the means to administer necessary medications quickly and efficiently. In some cases, patients may require supplemental oxygen therapy. This is only administered if there's a clear need, if the patient's saturation dropped below 90%. Pain relief is also a significant concern. We provide opioid analgesia, such as morphine, coupled with an antiemetic like metoclopramide to manage discomfort effectively. The cornerstone of STEMI management is reperfusion therapy. This should be initiated promptly, ideally within 12 hours from the onset of symptoms, using either fibrinolysis or primary percutaneous coronary intervention. Risk assessment is an ongoing process throughout management. We must consider the patient's age, existing comorbidities, and other factors to tailor our treatment approach. Concurrent with these steps, we administer a regimen of antiplatelet and anticoagulant therapy. This includes aspirin, P2Y12 inhibitors such as clopidogrel or ticagrelor, and anticoagulants like heparin or enoxaparin. For long-term management, we consider beta blockers and ACE inhibitors, provided there are no contraindications. These medications play a vital role in improving survival rates and preventing future cardiac events. Lastly, we must not overlook the importance of cardiac rehabilitation and secondary prevention measures. These are essential for improving the patient's quality of life and reducing the risk of subsequent cardiac events. As we have seen in the previous slide, the first step in the management of acute STEMI is establishing the diagnosis rapidly. Let's move on to the details. Diagnostic approach for patients presenting with suspected acute myocardial infarction. When you encounter a patient with chest discomfort, shortness of breath, or other symptoms that suggest a cardiac event, it's crucial to consider one of the acute coronary syndromes. Keep in mind that presentations can vary. Women, older adults, and individuals with diabetes may exhibit atypical symptoms, so stay vigilant. Moving on to the electrocardiogram, it's imperative to obtain a 12-lead ECG within the first 10 minutes of the patient's arrival. If the initial ECG doesn't give us a clear diagnosis, and you still have a high suspicion of a cardiac event, repeat the ECG every 10 to 15 minutes. Remember, the first ECG may not always be diagnostic. To set for the ECG criteria for ST elevation myocardial infarction, we will looking for ST segment elevations of 1 mm or more in 2 contiguous leads, or elevations of 2 mm or more in leads V2 and V3. Alternatively, a new left bundle branch block that aligns with an acute coronary syndrome presentation is also a criterion. If the ECG raises suspicion but isn't fully diagnostic, don't hesitate to consult a cardiologist early. Lastly, if you're managing a patient with acute coronary syndrome who is experiencing cardiogenic shock, left heart failure, or sustained ventricular tachyarrhythmia, it's essential to obtain an emergency cardiology consultation. This step is critical in providing the best care for your patient. Let's discuss the initial interventions in managing a cardiac emergency. First and foremost, we need to assess and stabilize the patient's airway, breathing, and circulation. It's crucial to attach cardiac and oxygen saturation monitors immediately and provide supplemental oxygen to maintain an oxygen saturation above 90%. Also, establishing intravenous access is a priority. In the event of sustained ventricular arrhythmia, it's imperative to treat it rapidly following ACLS protocols. Now, if we suspect a myocardial infarction and know an aortic dissection, we should administer 325 mg of non-enteric-coated aspirin for the patient to chew and swallow. If the patient cannot take by mouth, we can use a rectal suppository. A focused history and examination are next. We need to be on the lookout for signs of hemodynamic compromise and left heart failure. It's also important to determine the patient's baseline neurologic function, especially if we're considering fibrinolytic therapy. Let's not forget to obtain blood samples for cardiac biomarkers, with a preference for troponin, as well as electrolytes, hematocrit, and hemoglobin levels. For those on anticoagulants or with a known coagulopathy, coagulation studies are necessary. Let's continue from where we left off on the previous slide. If the patient is experiencing persistent chest discomfort, hypertension, or signs of heart failure, and there's no indication of hemodynamic compromise or recent use of phosphodiesterase inhibitors, we can give 0.4 mg sublingual nitroglycerin tablets, one at a time, 5 minutes apart, or an aerosol spray under the tongue every 5 minutes for 3 doses. Should the symptoms persist, we may consider adding intravenous nitroglycerin. In cases of left heart failure, afterload reduction is key. We can administer a nitroglycerin sublingual tablet or start an intravenous drip at 40 microgram per minute, ensuring there's no hypotension or recent use of phosphodiesterase inhibitors as these medications exacerbate the hypotension. The drip should be titrated quickly based on the patient's response. Additionally, a loop diuretic like intravenous furosemide may be given, and for appropriate patients, non-invasive positive pressure ventilation should be administered. If our patient shows no signs of heart failure, or doesn't have high risk for heart failure, and doesn't exhibit any hemodynamic instability, bradycardia, or severe reactive airway disease, we can consider administering a beta blockers such as metoprolol 25 mg orally. Now, in cases where the patient is hypertensive, we might opt for an intravenous beta blocker instead. For instance, we could use metoprolol 5 mg intravenously, repeating this every 5 minutes for a total of 3 doses, provided the patient tolerates it well. Moving on to morphine sulfate, this is our go-to for chest discomfort that doesn't respond to nitrates or other anti-ischemic treatments. The protocol here is to administer 2 to 4 mg via a slow intravenous push, and we can repeat this every 5 to 15 minutes as needed. Lastly, we want to start atorvastatin as soon as possible, ideally before percutaneous coronary intervention, especially in patients who are not already on a statin. The dose we're looking at is 80 mg. If the patient is already on a low to moderate intensity statin, we'll make a switch to atorvastatin, again at a dose of 80 mg. We have stabilized our patient. So, let's make a choice of reperfusion therapy between PCI and fibrinolysis. Since our main objective in the acute phase is to quickly re-establish blood flow in the blocked coronary artery, this is done through reperfusion therapy, which includes options like percutaneous coronary intervention or fibrinolysis. So, how do we decide which route to take? Well, this decision needs to be made swiftly, ideally within minutes of the patient's arrival. Once we've chosen our strategy, it's crucial to kickstart the local STEMI protocols immediately. These protocols are like a well-oiled machine. They set in motion the necessary personnel and resources, such as the interventional cardiologist and the pharmacist, and ensure that everything is in place for a quick transfer if needed, all to provide the reperfusion therapy as fast as possible. But how do we choose between PCI and fibrinolysis? Well, it's not a one-size-fits-all answer. We consider several key factors. The first is the time delay between when the patient first contacts medical professionals and when they can undergo percutaneous coronary intervention. We also need to consider how much time has passed since the patient first experienced symptoms. If the patient is in cardiogenic shock, this is a crucial factor that could influence our decision. Sometimes, there's diagnostic uncertainty, which means we're not completely sure of the patient's condition, and this can affect our choice of treatment. We must also be aware of any contraindications to PCI or fibrinolysis, which are situations where these treatments might not be safe for the patient. Lastly, we look at high-risk factors that might lead us to decide against reperfusion therapy. Each of these elements plays a vital role in determining the most appropriate and effective treatment for each individual patient. It's a complex decision, but by carefully considering each of these factors, we can make the best choice for our patient's health and recovery. Primary PCI is preferred to immediate fibrinolysis when both reperfusion strategies can be delivered in a timely manner. Let's delve into why we often prefer PCI over fibrinolysis. The primary reason is that PCI, when performed by experienced interventional cardiologists, can be more effective, especially if it's done within 120 minutes from the first medical contact, and ideally, we aim for within 90 minutes. But what about situations where PCI can't be performed quickly? In some cases, we might still go for PCI even if there's a delay. For example, if there's uncertainty in the diagnosis, if the patient has a high risk of bleeding, or if they're in a critical condition like cardiogenic shock, PCI might still be the better option. However, there are times when immediate fibrinolysis is the way to go. If both PCI and fibrinolysis can be administered promptly, we lean towards PCI. But if we're facing a delay in PCI that's over 90 minutes, then fibrinolysis becomes our preferred choice. It's particularly useful in places where PCI isn't available or when there's an anticipated significant delay in its delivery. Our goal is to start fibrinolytic therapy within 10 minutes of diagnosing ERMP. So, in summary, while we generally favor PCI, there are certain circumstances where fibrinolysis might be the better, or sometimes the only, option available. It's all about assessing the situation quickly and choosing the best possible treatment path for our patients. Let's continue our discussion on the acute management of STEMI with a focus on antiplatelet and anticoagulant medications. All patients should receive oral antiplatelet therapy in addition to aspirin. Here's how it works. If a patient has received fibrinolytic therapy and is 75 years old or younger, we administer a loading dose of clopidogrel, which is 300 mg. For those over 75, the dose is reduced to 75 mg. For patients who haven't received any reperfusion therapy, we give a ticagrelor loading dose of 180 mg. And for those undergoing primary PCI, the ticagrelor dose remains the same, or they might receive a prasugrel loading dose of 60 mg, provided they don't have any contraindications like a previous stroke or transient ischemic attacks. We also consider factors like age, weight, and bleeding risk. If prasugrel or ticagrelor aren't suitable, then clopidogrel 600 mg is our alternative. Now, when it comes to those undergoing primary PCI, our go-to is unfractionated heparin over bivalirudin. This is under the assumption that a potent oral antiplatelet, like ticagrelor or prasugrel, is being used, which we generally prefer over clopidogrel. However, if a patient is on clopidogrel, then bivalirudin becomes our anticoagulant of choice. Let's talk about anticoagulant therapy in patient with ST segment elevation myocardial infarction. For those undergoing primary percutaneous coronary intervention, our protocol favors unfractionated heparin over bivalirudin. This is particularly the case when a potent oral antiplatelet agent like ticagrelor or prasugrel is administered, which we prefer over clopidogrel. However, if clopidogrel is used, then bivalirudin becomes our anticoagulant of choice. For those undergoing primary percutaneous coronary intervention, we start unfractionated heparin with an intravenous bolus of 50 to 70 units per kilogram, not exceeding 5,000 units. Depending on the activated clotting time, additional heparin may be administered. As for bivalirudin, we begin with the 0.75 mg per kilogram intravenous bolus, followed by a continuous infusion of 1.75 mg per kilogram per hour, which can be stopped post-PCI. Moving on to patients treated with fibrinolytic therapy, enoxaparin is preferred for those without a high risk of bleeding, while fondaparinux is reserved for those with a higher bleeding risk. In scenarios where PCI is anticipated following fibrinolysis, unfractionated heparin is a reasonable choice. For patients not undergoing reperfusion therapy, we administer either enoxaparin or unfractionated heparin. The dosing for enoxaparin mirrors that for fibrinolytic therapy. For unfractionated heparin, we administer in 4 bolus of 50 to 70 units per kilogram, up to 5,000 units, followed by an infusion of 12 units per kilogram per hour. This is adjusted to maintain an activated partial thromboplastin time of roughly 50 to 70 seconds, which is about 1.5 to 2 times the normal control value. Alright, let's proceed with our quiz to see how well you've grasped these concepts. The clinical presentation of this 76-year-old male with diabetes, hypertension, chest pain, diaphoresis, and ST segment elevation in leads 2, 3, and if strongly suggests an acute inferior wall ST elevation myocardial infarction. In general, inferior ST elevation myocardial infarctions result from the occlusion of the right coronary artery in 80 to 90% of cases, or they may result from the occlusion of the left circumflex coronary in small proportion patients. On ECG, this can be recognized with ST elevations in the lead 2, lead 3 and AVF with reciprocal changes in the high lateral leads 1 and AVL. In the management of STEMI, timely reperfusion is critical to restore blood flow and minimize further myocardial injury. The options presented are all potential steps in the management of this condition, but they differ in immediacy and appropriateness given the clinical urgency. Option A, waiting for troponin results, is not the best immediate step. Troponin is a biomarker of myocardial injury which rises in the blood several hours after the onset of myocardial infarction and remains elevated for days. While important for diagnosis, the treatment for STEMI should not be delayed awaiting troponin results because the priority is to restore coronary blood flow as quickly as possible. Option B, consulting a cardiologist for possible percutaneous coronary intervention, is indeed the next best step. PCI is the preferred reperfusion strategy in STEMI when it can be performed in a timely manner, ideally within 90 minutes of first medical contact. This option aligns with current guidelines that emphasize the importance of early mechanical revascularization. Option C, performing echocardiography and considering dual antiplatelet therapy, is a valuable diagnostic and therapeutic step but not the most immediate action required. Echocardiography can assess the extent of myocardial damage and detect complications, while dual antiplatelet therapy is crucial post-reperfusion. However, these measures should follow the urgent reperfusion strategy. Option D, starting a therapeutic dose of anticoagulation after troponin results, is also not the best immediate step. Anticoagulation is an integral part of the management of STEMI, often initiated in the emergency setting, but it is adjunctive to reperfusion therapy and should not delay PCI. In summary, the diagnosis is acute inferior wall STEMI, and the immediate management should focus on rapid reperfusion via PCI, as indicated in option B. The other options, while important in the overall care of the patient, are secondary to the urgent need for reperfusion. Ladies and gentlemen, as we draw this session to a close, I sincerely hope that the discussion we've had today has not only been enlightening but also immensely enjoyable. Your engagement and curiosity are what make these conversations truly valuable. If you found the content of this video to be of merit, I would be grateful if you could express your appreciation by liking it. Your feedback is crucial, so please feel free to write to me in the comments section with your thoughts and insights. Sharing this video with others can extend the reach of the knowledge we've exchanged today, ensuring that many more can benefit from our discussion. Moreover, by subscribing to this channel, you will be promptly notified of any new content we upload, keeping you updated with the latest discussions and insights. I am eager to continue this journey of exploration with you, and I look forward to welcoming you to our next session. Until then, thank you for your time, your enthusiasm, and your willingness to learn and share. See you in the next discussion. Bye.